Hello, everyone, and welcome to today's webinar, Laboratory Diagnosis of Immune Deficiency. I am Michelle Ashton of Labroots, and I'll be your moderator for today's event. Today's educational web seminar is presented by Labroots and brought to you by Binding Site. To learn more about our sponsor, please visit www.bindingsite.com. Let's get started. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I now present today's speaker, Dr. Sarah E. Wheeler, Assistant Professor at the University of Pittsburgh, Associate Medical Director, Clinical Immunopathology at UPMC Children's Hospital of Pittsburgh, and the Medical Director of Automated Testing Laboratory at UPMC Mercy and UPMC Children's Hospital of Pittsburgh. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Dr. Wheeler, you may now begin your presentation.
Thank you so much, Michelle. Good morning, and thank you so much for attending our discussion of the laboratory diagnosis of immune deficiency. As mentioned, I oversee clinical immunopathology as well as the automated testing laboratory at Children's Hospital of Pittsburgh. So weekly, I'm consulting with clinicians regarding primary immunodeficiencies. So this is a topic near and dear to my heart. So today, we have a few learning objectives. Hopefully, we're going to understand the role of laboratory testing in diagnosing primary immunodeficiency disorders. We're also looking to be able to outline appropriate test utilization in primary immunodeficiency disorder screening. Lastly, we want to identify limitations in test utilization and implementation for primary immunodeficiency disorders. So a quick overview of PID, or primary immunodeficiency. There are about 250,000 people with PID in the US. Unfortunately, many still remain undiagnosed. It's an underdiagnosed disease with estimates that 70 to 90% of people with PID don't even know that they have it. PID itself is a genetic disorder that impairs the immune system. Genetic defects lead to missing or dysfunctional immune system components. The immune system defect can remain undetected due to no clinically significant symptoms, or it can be life-threateningly severe. The spectrum is wide, and the number of primary immunodeficiencies is currently over 300 identified and counting. There's a lot of expansion happening here due to the increased availability of genetic testing. Aside from our patients that have no clinically significant disease manifestations, there are many more that remain undiagnosed because the signs and symptoms often look much like normal childhood diseases, or in some cases, adult infections or diseases. There are many warning signs that might look like standard childhood illnesses that we should pay attention for. If there are 4 or more new ear infections within a year, 2 or more serious sinus infections within a year, 2 or more months on antibiotics with little effect of the antibiotics on the infection, 2 or more pneumonias within a year, failure of an infant to gain weight or grow normally, which accounts for most of the cases we see at Children's Hospital, but combined with some of these other indications can be cause for concern. Recurrent deep skin or organ abscesses, persistent thrush in the mouth or fungal infection on the skin, any need for IV antibiotics to clear infections should raise red flags for us. 2 or more deep-seated infections, including septicemia. And since PID is a genetic disorder, any family history should really prompt increased attention to PID diagnosis. So there are 4 stages of testing that have been outlined. The Jeffrey Modell Foundation has pulled together a large number of PID experts to be able to develop these 4 stages that are listed here. These can help get the appropriate diagnosis much faster, also preventing many of the complications that often come from undiagnosed PID. Looking just at stage 1, which is history and physical exam, including weight and height, a CBC with diff, as well as quantitative immunoglobulin levels with the age-appropriate interval, it's estimated that about 75% of PIDs can be diagnosed looking at just this stage 1. The CBC can be particularly helpful as a first look at T-cell and phagocytic-related deficiencies, while the quantitative immunoglobulins, or QIGs, can provide a first look at B-cell-related defects. Stage 2 starts to get a little bit more specific. We're looking at specific antibody responses to vaccines. Most subjects, vaccines are administered with very stringent regulation of dosage, how much adjuvant is present, route, and schedule. So evaluation of the vaccine response through the measurement of their antibody titers in serology can provide some measurement of antigen standardization between patient populations. Some patients have antibody failure against bacterial polysaccharide antigens, but are able to respond to immunization with protein antigens and in the opposite direction as well. So the measurement of IgG subclasses concentrations is fairly standard and can help in understanding some of these immunization responses. It's also standard for us to look at subclasses in the suspicion of any antibody deficiency, particularly when the total IgG is within that normal age-specific reference range. The measurement of these subclasses is also useful for the diagnosis of IgG subclass deficiency specifically, and to aid in the diagnosis of specific antibody deficiencies as a supporting test for common variable immunodeficiency, and then we also use it for some risk stratification of patients that have IgA-specific deficiencies. So our stages 1 and 2 are covering most of the common PIDs, but stages 3 and 4 begin to tease out some of the less common primary immunodeficiencies, including cellular and phagocytic deficiencies. They're also looking to narrow the specific deficiency mechanism. So as we move into stage 3, T-cell disorders can be confirmed by a lack of delayed hypersensitivity skin testing response. Specifically, we often look at candida, mumps, or tetanus. Obviously only in children older than 1 year who have actually been exposed to those through vaccines or environment. Lymphocyte subtest analysis can also be used at any age and screens for the number and percentage of T cells, B cells, and natural killer cells. Those are the surface markers that are listed. Lymphocyte proliferation studies also look at T cell function, which provides insight into cellular and combined immunodeficiencies. Also determines paired T cell function by culturing human peripheral blood mononuclear cells. We do that in vitro with mitogens and antigens, and that is usually assessed by flow cytometry. Stage 4 moves into testing for more specific and less common deficiencies, and is usually requested and assessed specifically by clinical immunologists. Laboratory testing is critical in quickly and accurately diagnosing primary immunodeficiency disorders. Stage testing helps us provide a rapid rule-in or rule-out diagnosis and prevents this kind of testing anemia that we often see in our tiny patients at Children's Hospital when we take far too many samples for the small amount of blood that they have. So looking at the classification of PID as well as its distribution, there are official PID classification criteria that have been agreed upon by the International Union of Immunological Societies Expert Committee for the classification of primary immunodeficiency. And these particular numbers come from physician reporting on PID that was used in a survey, again performed by the Jeffrey Medell Centers Network. And it helps provide a bit of an indication of current disease distributions. In the US and globally, the predominantly antibody deficiencies account for the majority of PIDs, about half. That said, an inherent bias in this data is that all of these are diagnosed cases because they are reported by physicians. Combined immunodeficiencies and other unspecified deficiencies accounted for the next largest groups. Phagocytic defects account for less of this percentage than I've actually seen in other reports. I'm not sure if this is due to sampling bias or changes with time, but there is a sense that phagocytic defects may actually be a bit higher than listed here. So when we're thinking about primary immunodeficiencies, it helps to step back and take a simplified look at the immune system. Immune response can be broken down into the innate and acquired immunity. Innate immunity doesn't require prior exposure to an antigen, so it can respond immediately. It recognizes primarily generalized antigen molecules rather than antigens specific to an organism or cell. Components include complement, phagocytic cells, that'd be our neutrophils, monocytes, macrophages. All of these work to ingest and destroy invading antigens. Natural killer cells, polymorphonuclear leukocytes, again, neutrophils, eosinophils, basophils, as well as mononuclear cells, monocytes, macrophages, mast cells. These all release inflammatory mediators. Acquired immunity, on the other hand, takes some time to develop after the initial exposure, but with a new after the initial exposure with a new antigen, but after that first exposure, the immune system is much quicker to respond because it has memory. So the acquired immunity includes T cells, which would be cell-mediated immunity, and B cells, which we often term humoral immunity. So immune cells differentiate from stem cells in the bone marrow, which we see starting at the top of the slide. And at each step of the differentiation, the cells become increasingly specialized. And at each of those steps, there are opportunities for genetic defects to throw a wrench in the works and create what we now term primary immunodeficiencies. So here we have a few of the origins of PID defects. Again, there are over 300 of these, so we're not doing a comprehensive look at that. But as you can see, at each stage, mutations in a gene can cause defects in downstream immune functions. Some mutations can affect multiple systems, and some have effects beyond just the immune system. If you look at the ones in black that are more towards the right of the screen, those are examples of combined B and T cell primary immunodeficiencies, with the most severe being reticular dysgenesis at the top. In green are examples of mostly B cell related PIDs, and in red to the left are PIDs associated with defects in phagocytic cells. In red to the right is the PID associated with primarily T cell function. What you'll notice is that many PIDs really have overlap between classes in any of the classification systems used. And just another look at an estimate of PID distribution. This estimate actually also looks at undiagnosed cases. It creates an estimate around undiagnosed cases, and it indicates, again, that these predominantly antibody deficiencies account for a little over half of PIDs, with combined immunodeficiencies and defects in phagocytic cells following at about 10% of all PIDs each. This demonstrates quite well why a CBC and a quantitative immunoglobulin with a medical exam and history can really diagnose, or perhaps it's a little better to say identify, about 75% of PIDs. So for my brain, looking at the very complex classification system can be a little difficult on the day-to-day basis as we are triaging cases that are coming in and the testing that's being done on them. So I like to simplify the classification a little bit. So from the differentiation of the immune system, it can be a bit easier mental shorthand to think of PIDs in these simplified categories, looking at B cell related, T cell related, combined, complement, and phagocytic. Again, not perfect categories, but they're useful as we start trying to work through cases. And I've listed a few examples of these on the right for reference. This is another reference, another useful way for us to think about primary immunodeficiencies is associating them with the indications for the disorders. So a few themes present here as you scan down. Increased infections, obviously, and in particular, increased opportunistic infections. Also infections that are more severe in their course than you would expect to see. Increased autoimmune disease, particularly eczema, comes up quite a bit, as well as allergies. Malignancy is also a common theme among many primary immunodeficiencies. Because the presentation of so many PIDs has many symptoms that could be somewhat normal in childhood, the PID community often identifies primarily with the zebra. So in addition to this being a very adorable cartoon that's really applicable to all ages, kids and adults can identify with the zebra, it's based on a thing that many of us learned in our medical training, that when we hear hoofbeats, we should think horses, not zebras. And we're really taught to focus on the likeliest possibilities when making a diagnosis, not the unusual ones. And that is often very sound advice. However, sometimes we do need to look for the zebra, and people with PID are often the zebras in the medical world. So with that, we're going to look at a few zebras. We're going to move into some cases that have come through either the laboratory or my clinical immunology counterparts have addressed. So case one is Timothy. Obviously, all of the case names are made up. Timothy's first presentation was at 1 year of age. He was born full term, didn't have any prior hospitalizations, no significant past medical history. This was his first time really coming in for anything besides wellness visits. He comes from a non-smoking household and doesn't attend daycare. He actually receives care in his home via grandparents and part-time working parents. He lives at home with his parents, and they do have 2 puppies. And he presented at the ED with a neck abscess of 2 centimeters on the left side. And a CT scan was done and showed a round enhancing mass. He recently had what they suspected was hand, foot, and mouth disease, not at all uncommon for his age. He was admitted. He went to the OR where they drained the cyst. And in looking at the fluid, they found that it was pus and it was gram-stained and found to be gram-positive for cocci. And the culture revealed that it was an MSSA. IV penicillin was given while he was in the hospital, and he was discharged on amoxicillin. 1 week later, after being discharged, and while he was still on antibiotics, he returned with a 3-centimeter mass that was just below the incision site. He was again admitted, went to the ER, they drained it again, and he was discharged home a few days later again on amoxicillin. 1 year later, poor Timothy comes back. So he's had a month history of daily fevers. His father reported that he initially noticed that Timothy felt warm and started checking his temperature, and that over the last month, they were noticing that he had fevers generally ranging at about 102 degrees Fahrenheit that occurred mostly in the late afternoon or evening. He hadn't had other significant symptoms, and he'd been healthy since his cyst hospitalization a year ago. And his dad never really felt like he looked sick throughout all of this, which is why they hadn't brought him in before. His history, as well as the exam that was done in the ED, were really unrevealing for the origin of the fever. Testing was sent out. It came back, and he had normal electrolytes, including calcium and albumin, as well as normal liver function tests. CBC and DIF were essentially normal, except that he did have a mild anemia with a hemoglobin of 10.7 grams per deciliter, hematocrit of 32%, and thrombocytosis with a platelet count of 315,000. His CRP was slightly elevated, it was elevated at 6.7 mg per liter. They also sent EBV titers and Bartonella titers, and those were both negative, as was his urinalysis. They also decided to do some imaging, so we had a chest x-ray, an abdominal ultrasound, that was negative. They looked at tuberculosis testing, that was negative. They decided to do an echocardiogram, so there was concern about Kawasaki disease, and there was nothing consistent in the echocardiogram with KD. He did have a mildly elevated ferritin, but 2 blood cultures came back negative, and the CMV PCR was negative. They also sent out for toxoplasma serology. That was negative. They did do a virus swab, and that tested positive for enterovirus and rhinovirus, but that didn't seem to explain his illness. They also did some stool testing for ova and parasites. That was negative. So they decided to order quantitative immunoglobulins to look into this a little more. Looking at his quantitative immunoglobulins, they were essentially normal with just a slight increase in IgM that wasn't really considered significant. On that, rheumatology was called in for a consult, and they added juvenile idiopathic arthritis to the differential, which included, the current differential was including occult infection, periodic fever syndrome, as well as malignancy. And fever is sometimes seen in JIA that the fevers are present for some time prior to the onset of the arthritis or rash, and the possibility of periodic fever syndrome couldn't really be completely excluded, but usually in that the fevers are actually periodic and not acute in onset and then persistent, as Timothy had been seeing. And usually periodic syndrome is accompanied by other symptoms. There weren't any diagnoses given. There was no discrete symptom that could really guide management, so they wanted to see if this could continue to become a picture consistent with juvenile idiopathic arthritis. So Timothy was going to have to be monitored. His mom was to check him for the signs of JIA, which included the classic evanescent salmon-colored rashes under his arms and his diaper area during fevers, as well as keep a diary of any evidence of arthritis. So he was discharged to home, but a month later, he came back to the emergency department. This time, he had ascites in his abdomen. It had an unclear etiology. His labs were showing continued elevation of CRP and a chronic microcytic anemia. And apparently, I really wanted to be sure that it was clear that this was microcytic, as I repeated that twice. He also had a persistent thrombocytosis and hypoalbuminemia, which could be consistent with the general picture of chronic inflammation that appeared to be building. The paracentesis found the ascites to be purulent with a white cell count of 10,000, which was consistent with an exudate. At this hospital visit, there was a new family history of Crohn's disease as well, so a few other tests were sent. The fluid cultures from the ascites remained negative, and it appeared that overall this was consistent with an inflammatory etiology, but it wasn't really clear if that was inflammatory bowel disease or perhaps systemic onset JIA. So at this point, poor Timothy was definitely at risk of becoming one of our blood drawing anemia-related patients. He had a host of testing done, and he was already anemic, and we probably worsened that. To date, all of the testing had been ruled out, and he was negative for this whole host of testing that included a periodic fever genetic panel that was sent out. A CT scan of his abdomen was consistent with peritonitis, and due to the findings of the CT scan, as well as secondary to these continued fevers and abdominal distension, they went ahead and started him on antibiotics for the possibility of spontaneous bacterial peritonitis, and he headed home. About 4 days into the antibiotic treatment, his fevers did stop, which was helpful. Again, another month later, he was back. He again had ascites. This time it contained macrophages, monocytes, and acute inflammation markers. It was decided to do an exploratory laparoscopy with paracentesis at that time. They also did a peritoneal biopsy, liver biopsy, as well as colon and small vessel biopsy to try to rule out or rule in something. The peritoneal biopsies in particular showed organizing peritonitis with rare palisading and epithelioid granulomas. So the granulomas specifically were thought by pathology to be related to the pathogenesis of his disease process, as opposed to, so tuberculosis is actually the most common cause of these kinds of findings, but the skin testing for tuberculosis had already been negative, as had been the acid-fast stain. So the ascites secondary to primary bacterial peritonitis has actually been reported as an initial presentation, though a rare one, of chronic granulomatous disease, or CGD. And to follow that up, they decided to order a NOVA test, which we'll talk about in just a moment. Sarcoidosis was also considered on his differential, so ACE levels were sent for this. The ACE levels did come back negative, but he was found to have a lack of oxidative burst on his neutrophil oxidative burst assay, which is a NOVA assay, and that's consistent with what we see in CGD. Further testing revealed that his younger brother also had CGD when they did follow-up after finding Timothy's CGD, and his mother was presumed to be a carrier, although she had been asymptomatic. They did some further genetic testing that showed that his hemizygous for this C1683 dupe G, and that's in the CYBB gene, which, while it hadn't really actually been previously reported in CGD, this was the first time, it was consistent with the diagnosis of X-linked CGD. To date, Timothy's done well on prophylactic antibiotics, and the family is considering a bone marrow transplant at this time for him. So CGD itself is an X-linked or autosomal recessive disorder of phagocytes. It stems from a deficiency in the NADPH oxidase, which is required to make reactive oxygen species that are used to kill invading organisms. As you can see, the oh no of the organisms on the right being killed. NADPH oxidase results in a rapid oxidative burst, but CGD patients can actually only use peroxide from organisms that make reactive oxygen species, so they're at increased risk of catalase-positive organisms, and this inability to kill invading organisms is actually what leads to the granulomas that characterize CGD. So if we look at a little more closely at the mutations in NADPH, the underlying defect is obviously the impaired generation of activated forms of oxygen, such as superoxide, and that's actually due to a variety of enzymatic defects that have been found that lead to CGD, and that involves the NADPH oxidase system, which is multi-component, and it's required for the generation of superoxides as well as their metabolites, hydrogen peroxide and bleach. The structural components of these are referred to as FOX enzymes, PHOX, which is phagocyte oxidase proteins, and you can see those slightly in the upper right corner of the lower box. At rest, the complex sits as separate components, but they bind tightly as soon as neutrophil activation occurs, and that forms that intact NADPH oxidase. So this complex actually harvests an electron from NADPH and donates it to molecular oxygen, which creates the superoxide. and that is what's required for the phagocytes for phagocytes being able to kill microbes. Mutations in the NADPH oxidase components cause CGD, and more than 50% of CGD cases are actually from the X-linked recessive trait. It occurs only in males for the X-linked, but there is also an autosomal recessive inheritability as well. The common mutations that are responsible for CGD affect the GP91 FOX, which is the X-linked form, as well as several of the other genes associated with the NADPH complex. So the clinical features will often include those listed, and up to 5% of these patients also have autoimmune diseases. Laboratory features may include anemia with an elevated CRP, which we saw in Timothy's case, and they may also demonstrate hypergammaglobulinemia and a normal white blood cell count. So NBT, which is also called NBT, which is nitroblue-tetrazolium, as well as DHR, which DHR is also called, referred to as NOVA, are the diagnostic assays that we use to assess the oxidative function of the NADPH oxidase. Treatment generally tends to be prophylactic antimicrobials, interferon gamma, and if the patient is a good candidate, bone marrow transplant is recommended to improve outcomes. So looking at the testing that we do for CGD, NBT and NOVA both assess the lack of NADPH oxidase function, which is what is the heart of CGD. So the nitroblue-tetrazolium assay, it was the most common diagnostic test for CGD previously. It's quite straightforward and easy to run. It's based on direct reduction of NBT by superoxide free radical to form an insoluble blue formazine in the normal patient, and then in the absence of blue is what we see in the CGD patient because they can't actually convert the light yellow colorless water-soluble compound. It's been largely replaced, however, by the flow cytometric assay. So that's dihydrorhodamine, or DHR assay, also called NOVA for neutrophil oxidative burst assay. It now tends to be preferred. It's fast, it's pretty easy to use, and it can actually distinguish X-linked from autosomal patterns of CGD, which is helpful. It's also very sensitive to low numbers of functional neutrophils, which makes it great, particularly in the pediatric testing we do. NBT continues to be simple to perform and provides rapid results and is still used in many settings. For both tests, neutrophils have to be activated. That usually happens with PMA to stimulate the oxidative burst. Essentially, once the diagnosis of CGD is established, genetic analysis might also be used to determine exactly which mutation is the underlying cause. However, all of them will be associated with this lack of NADPH oxidase enzyme activity. So Elizabeth is our second case. She came to us as a 5-year-old female with well-controlled mild persistent asthma. She has allergic rhinitis, and specific IgE testing showed several environmental allergens. She also had a clinical reaction to A and P and subsequently demonstrated elevated specific IgE to both of these components. She's had a poor response to the pneumococcal vaccine and a history of 2 pneumonias recently. She was supposed to continue her current asthma and allergy treatments and avoid all food allergens. She was also considering immunotherapy if her asthma remained well controlled. She was also revaccinated with the pneumococcal vaccine to try to prevent additional pneumonias when she presented to the immunology clinic. This was kind of our first blush with Elizabeth, and we didn't see her again for actually 6 years because she was being primarily followed outside our system. 6 years later, she came as an 11-year-old female with a history of asthma. Eczema had started, her allergic rhinitis and food allergies continued, and she was now experiencing more recurrent MRSA skin infections and wanted to be reevaluated. Again, she was primarily being followed locally by an immunologist specialist in her area, but we were getting into the winter months and she wanted to be reassessed because her asthma tended to flare in the winter. Unfortunately, this time later, her asthma symptoms no longer seemed to be ideally controlled based on her ACT score, but she wasn't frequently using her rescue inhaler and didn't have any nighttime symptoms. Her pulmonary function tests were promising, so that wasn't of super high concern, but we did want to get that under better control. She was still avoiding her food allergies, which included green peas, peanuts, and eggs, and she hadn't actually had a serious reaction to any of those food allergies that required her EpiPen for many years. Her specific IgE testing also revealed an elevated IgE. So it turned out, in discussing with her parents, it seemed that there was a strong family history with both her sister and her paternal cousin having high IgE levels that had also been discovered during specific IgE testing. And there was a bit of rumor that that was also happening in other paternal relatives as they were tested for allergies. She also had eczema that seemed to be well controlled with moisturizers overall. And given her elevated IgE, as well as the family history that her mother reported, she was referred to genetics for further evaluation to see if she and her sister, who also had not been to genetics, should pursue any genetic testing for hyper IgE syndrome. So at this point, the immunologist also ordered repeat quantitative immunoglobulins, B and T cell subsets, BBC, ANCA titers. So the ANCA titers were actually ordered to evaluate for eosinophilic granulomatosis, as well as polyangiitis, given her asthma, allergic rhinitis, as well as her elevated eosinophils. She was found to have inadequate antibody titers to diphtheria, and was given a Tdap booster at this particular visit, and was told that she needs to have those titers checked 6 weeks post-booster so we could make sure that she was protected. While she didn't have any major infections, she has had 2 minor that have required antibiotics in the last year. And it was notable, as you can see here, we got a picture that she'd been retaining her baby teeth that were starting to crack as her adult teeth were growing in. So 2 years later, Elizabeth again returned to us after following up at the outside clinic. Since her last visit, she'd again had multiple MRSA infections, severe asthma, eczema, and now a confirmed family history of AD hives. And she was presenting to the primary immunodeficiency clinic for follow-up for this autosomal dominant hyper IgE syndrome. Her genetic testing was consistent with that of both her sister and her paternal aunt, and that was a STAT3 mutation, which is very common in hyper IgE syndrome, and it's likely a pathogenic variant that we've got noted here. She also had had a few other things done since her last visit. She had 2 baby teeth pulled due to retention. She was found to have scoliosis, and she was getting a back brace for that. At the moment, she's got fatigue, productive cough, shortness of breath. She's wheezing on exam. Her asthma is not improving. Decreased breath sounds in the left lung fields. Overall, her picture was very concerning for pneumonia with an asthma exacerbation. There wasn't any radiologic evidence of pneumonia present, but with her symptoms being consistent with pneumonia and poorly controlled severe asthma, she was at very high risk for developing long-term pulmonary complications if it was a pneumonia that went untreated. So she was empirically treated with antibiotic and steroid, which would be quite common in hyper IgE syndrome. So her quantitative immunoglobulins were showing kind of across ages here, and they've continued to demonstrate relatively normal levels of IgA, IgG, and IgM for her age. There's a slight decrease in IgG in her most recent testing. IgE has consistently been increased, which is in keeping with her diagnosis of autosomal dominant hyper IgE syndrome. And IgE at this level is sometimes outside of the linear range of the instrumentation, and it's important that validation be done if dilution is going to happen on these samples that are outside of the linear range. It's also important to note that there are age-appropriate reference ranges provided by the laboratory. So as the immune system is developing, the appropriate level of immunoglobulins change at each age, and you can see how much those reference ranges change as she moves from 5 years to 13 years. So looking a little bit at the variant information associated with hyper IgE syndrome. So she has this STAT3 mutation that's likely pathogenic, and it's also associated with autosomal dominant infantile onset multisystem autoimmune disease, and that's because of the STAT3 gain of function. It's characterized by early onset of autoimmune conditions in multiple organ systems, which can include type 1 diabetes, celiac disease, autoimmune enteropathy, autoimmune hematologic disease. And there are other commonly reported features: short stature, primary hypothyroidism, juvenile onset arthritis, interstitial lung disease, alopecia, eczema, which we saw for her, as well as nonspecific dermatitis. Hyper IgE recurrent infection syndrome is very common, and we want to try to keep these patients out of that. So identifying hyper IgE early is very important. And it's really characterized by a triad of findings, including recurrent skin abscesses, pneumonias, as well as significantly elevated IgE levels with onset in early childhood, which we did find here in her case. Common features include eczematoid rashes, candiditis. Skeletal features include recurrent fractures, joint hypermobility, vascular abnormalities, scoliosis, which we did see here in Elizabeth's case, as well as the retention of primary teeth. And Elizabeth had several of these things, particularly the scoliosis and the retention of primary teeth, which was seen in both her and her sister, and is a bit of a giveaway for hyper IgE syndrome. Most affected individuals do survive into adulthood, but the lifespan can be shortened due to complications with cystic lung disease, as well as recurrent pneumonias. So overall, hyper IgE is associated with a defect in neutrophil chemotaxis. It's most often autosomal dominant with these mutations in STAT3. And we know that the Th17 cells are impaired in their maturation, and neutrophil recruitment is also impaired. It's also associated with inadequate interferon gamma response. But the STAT3 protein is actually involved in a lot of systems besides just the immune system, and the mutation causes other physiologic manifestations, such as skeletal abnormalities. And it's really unclear how the STAT mutations actually lead to increased levels of IgE. There's been a reasonable amount of work on it, but we still haven't actually teased that out. So hyper IgE syndrome is actually also known as Jobs syndrome, and it's a rare multi-system primary immunodeficiency disorder. The symptoms often become apparent early during infancy or childhood, and it's characterized by the repeat bacterial infections, as we were seeing with Elizabeth, of the skin and lungs. Many of these skeletal abnormalities, as well as characteristic facial features, manifest themselves. And the first symptom is often development of a dry, red, flaky skin rash, such as eczema, at birth or early during infancy. Researchers have looked at the mutations in the STAT3 gene that are causing over 60% of the that are causing hyper IgE in about 60% of patients with hyper IgE. And most of these cases actually occur as the result of a new mutation in the gene. There are two main forms of hyper IgE syndrome. One is inherited in the autosomal dominant pattern, and one is in the autosomal recessive pattern, but both involve defects in the immune system with these elevated levels of immunoglobulin E, obviously. Unfortunately, we don't have any single diagnostic test, but the elevated levels of total IgE on allergy testing are often the beginning of the road to diagnosis for hyper IgE. So case 3 is Jane. Jane came to us on this hospital admission as a 2-year-old female. She had oculocutaneous albinism and presented with a fever and malaise that was uncharacteristic of her usual rather spunky self. Her CBC demonstrated mild anemia, mild thrombocytopenia, as well as mild neutropenia. She had lymphadenopathy, and this was actually her 4th infectious episode this winter, for which she'd been given antibiotics. She didn't do as well on the antibiotics as they anticipated, and a week later her parents brought her back to the ED. She had an increased fever as well as lethargy. At this hospital admission, the CBC confirmed the mild anemia as well as the thrombocytopenia and neutropenia, but additionally the neutrophils contained large granules, and the reactive lymphocytes contained large eosinophilic granules, and there was concern that there might be a hematologic etiology for some of the symptoms that were being noted, so that prompted a bone marrow aspiration and biopsy. The bone marrow examination revealed a mildly hypocellular marrow and granulocytes that contained abnormal and large eosinophilic granules. So based on the patient's history of oculocutaneous albinism, as well as the peripheral blood smear that had been done and the bone marrow that both contained large granules within the leukocytes, she was diagnosed with Chediak-Higashi syndrome. So CHS, as it's often referred to, is a rare autosomal recessive disorder that presents with a diverse collection of symptoms because of the global effects of the mutated gene. The LIST gene, which is also called CHS1 for obvious reasons, is the source of the defect, and it provides instructions for the lysosomal trafficking regulator protein. And we think that that plays a role in the transport or trafficking of materials into lysosomes, but the full function of that protein is still being worked out. Granulocytes, as well as cytotoxic T cells in patients with CHS, contain these very characteristic large distinct granules with dysfunctional lysosomes. And these are incapable of actually appropriately undergoing granule release, and in response to bacterial or viral infections. The patients that present with CHS are usually young children, and they have partial oculocutaneous albinism, which is likely from a variant melanosome fusion within the melanocytes. And they often present with recurrent pyogenic infections due to dysfunctional granulocytes. CHS results in recurrent infections at an early age, usually showing up in infancy to early childhood, which is the case for Jane here at 2 years old. And that's usually their presenting complaint. The presence of the giant granules in the white blood cells is actually considered diagnostic. So this pattern that we see here is the diagnostic lab test for this. So case 4 is William. William actually presented a bit later than many of our prior cases. He was presenting for follow-up as his pneumonia hadn't really responded as quickly as anticipated under prior treatment. He was a full-term birth, and his recent bout with pneumonia was the Urovecchi form of pneumonia. He has a history of frequent sinopulmonary infections, and his CBC, T and B cell subsets, as well as quantitative immunoglobulins, were ordered to follow up with this pneumonia. So his CBC demonstrated neutropenia. His T and B cell subsets were normal, but there was some confusion around the appropriate reference intervals for his quantitative immunoglobulins. They were transferred into the EMR incorrectly from an outside hospital, and there wasn't any age-appropriate reference interval included. On inquiry to the outside hospital where the testing was run, the listed reference interval was given, but the IgM range seemed a little bit low to the immunologist as well as to our lab when we looked at it. So we pulled reference ranges from a few institutions to aid in interpreting William's test results. And when we looked at it, the question arose, was his IgA actually low or normal? That depended a little bit on which specific range you were using. And was his IgM slightly elevated or was it normal? He clearly had a low IgG and a slightly low IgA with a relatively normal IgM level. So we verified the age-appropriate reference intervals, and that was all determined. But it's important as we're implementing many of these tests that age-appropriate reference intervals are included, particularly in pediatrics, as the immune system is still changing quickly in kids as they're developing, and the reference intervals can actually change in every year as they develop. And these deficiencies really will only be caught if an appropriate interval is used for comparison. So given the low IgG and IgA and the normal IgM, follow-up testing was done, and William was diagnosed with X-linked hyper-IgM syndrome. So X-linked hyper-IgM is actually caused by the absence or mutation of CD40 ligand, which is usually expressed on activated CD4 T lymphocytes. The absence of CD154 actually interrupts B cell differentiation by somatic hypermutation and the heavy chain switch from IgM to other isotypes. In this case, the B cells end up only producing IgM because they can't undergo the heavy chain class switching, and the IgM levels can be normal or elevated. Patients with the X-linked form may have severe neutropenia. We saw some neutropenia in William, and they often present during infancy. And it's very characteristic that they have this pneumocystis Urovecchi pneumonia. Lymphoid tissue is often very small because the deficient CD40 ligand signaling doesn't activate B cells. Otherwise, the clinical presentation is quite similar to X-linked agammaglobulinemia and can include recurrent pyogenic bacterial sinopulmonary infections during the first or second year of life. So in addition to the X-linked form, there are at least 4 autosomal recessive forms that involve a B-cell defect. In 2 of these forms that I've listed here, the serum IgM levels are actually much higher than in the X-linked form, so we would definitely see the IgM coming up at 2 or more times the upper reference range. And they're associated with lymphoid hyperplasia, as well as autoimmune disorders are much more likely to be present, and leukopenia can also be seen. The diagnosis of hyper-IgM syndrome is usually suspected based on clinical criteria, and the serum IgM levels are measured. Normal or elevated serum IgM levels and low levels or absence of IgG and IgA also support this diagnosis. Usual follow-up testing will include flow cytometry of the CD4 ligand expression on T-cell surfaces, and when possible, the diagnosis is usually confirmed by genetic testing, although that's not really required. Other laboratory findings that we might see as we're testing these kids include a reduced number of memory B cells, which would be the CD27 marker, as well as an absence of class-switched memory B cells, often IgD CD27. So when we try to put X-linked hyper-IgM in the context of the immune system, we can see that the mature B cell is present, but there's actually a block in the ability to class switch. So that's going to show itself. It's the XHIM that's showing it about the middle of the screen. You can see there are 3 boxes right about the middle that are preventing that class switching to IgG, IgE, and IgA. So we're only ending up with the IgM. That decreases the IgG, A, and E production, obviously, but IgM's intact. So class switching, the loss or mutation of the CD40 ligand actually impairs the B cell differentiation by somatic hypermutation and the heavy chain switch from IgM to other isotypes. In the presence of cytokines, normal CD40 ligand interacts with the B cells, as you can see in the center, and thus signals them to switch from producing IgM to producing IgA, G, or E. But in the X-linked hyper-IgM syndrome, the T cells lack functional CD40, so there's no signal actually happening to the B cells to switch. That's how we end up with just IgM. So a few of the clinical features, again, the opportunistic infections, as well as some rare forms of pneumonia are very common. In terms of laboratory, the elevated to normal IgM in the face of decreased IgG and IgA is a major giveaway for this, and pancytopenia is not uncommon. So usually you're looking at prophylaxis for this with antibiotics. IVIG is also very common, and bone marrow transplant is very helpful as well. So Charlotte came to us a little bit older. She was an 11-year-old female that presented with her parents and brother for evaluation for possible primary immunodeficiency. Her parents reported that when she was a young child, she had constant rhinorrhea as well as earaches. She was treated with multiple oral over-the-counter antihistamines and nasal sprays, but there was just no improvement. Finally, her tonsils and adenoids were removed, but she continued to have what her parents described as lagging colds. She had skin prick testing done to look for aeroallergens, and reportedly that was negative. She also has mild persistent asthma, and that's been well controlled. She hasn't had to have any oral steroids for the last year. A few years ago, she also reported having constant nausea and constipation and had been referred to GI. There, her parents report that she had normal scopes and pH probes performed as part of the evaluation, but in the course of the workup, the gastroenterologist actually obtained serum immunoglobulins and noted that they were all somewhat low. So she was at that time told that she should follow up with her PCP, who continued to monitor her immunoglobulin levels, and she was ultimately referred to a private allergist for continued surveillance. She had had her immunoglobulins followed as well as vaccine titers, and had been told in the past that she had lost all of her immunity to her vaccines. Her mother reports that she'd been clinically diagnosed with chickenpox as well 3 times, despite having been vaccinated. Her parents and Charlotte both reported that she's never really feeling good. She's always low on energy, and they estimate that she misses about 20 days of school a year for illness. So thinking back to all of the things we should be concerned about for primary immunodeficiency, she checks several of those boxes. So when we look at her current testing, we see markedly decreased IgA, with perhaps a very slightly low IgG and a normal IgM. Her IgG subclasses also all come up essentially normal, as does her CBC, her B cell panel, as well as her T and B cell counts. Her complement was also normal, and she seems to have retained her tetanus titer, so she had a booster 6 weeks prior, and her titers came back normal. And she also had an essentially normal B cell panel, and she hasn't needed any antibiotics since her visit last spring, although, again, coming into winter, that may change. So given all of this, Charlotte seemed that she likely had a selective IgA deficiency with a variable response to vaccines. Selective IgA deficiency is very common among primary immunodeficiencies and is often associated with an IgG subclass deficiency, hence the subclasses were ordered, and that's usually an IgG2 subclass deficiency, although IgG4 has also been noted. As of this time, they went ahead and started her on September through May prophylactic antibiotic treatment to reduce her wintertime infections, and decided to move forward with conservative treatment as there were no major symptoms that they felt required IVIG at the time. So selective IgA deficiency is the most common and mildest of the B-cell immunodeficiency disorders. Most patients are asymptomatic, and the finding often is incidental to other testing. These patients are at an increased risk for respiratory and GI infections and are characterized by low levels or complete absence of IgA. We saw low levels here with Charlotte. Looking again back at our immune system overview of B-cell immunodeficiency disorders, we can see that selective IgA deficiency has a pretty small effect on the full B-cell component of the immune system. So you can see down in the bottom right corner the effects only happening in that small part of the diagram. Hence, many of these patients are asymptomatic. Charles came to us as an 8-year-old boy. He presented for further evaluation of some abdominal pain he'd been having, as well as altered stooling patterns. He's had the symptoms for quite a while, but they seem to be more frequent since he started school this year and look like they're associated with stress. He hasn't had any weight loss, no appetite concerns, no reflux, vomiting, trigger foods that seem to be associated with the symptoms, but there is a significant family history of irritable bowel syndrome. Part of his testing included a workup for celiac disease related to this, and his tissue transglutaminase IgA as well as his deamidated gliadin peptide IgA were ordered, but the laboratory couldn't report them. Quantitative immunoglobulins, actually, that were ordered at the same time revealed that Charles had an undetectable level of IgA, making IgA celiac serologies not useful. The IgG serologies were run instead, and both were negative. While inflammatory bowel syndrome has been reported in IgA deficiency, the physician that was treating Charles didn't feel that the current symptoms were actually related to his IgA status. He likely has a selective IgA deficiency, but at the moment he appears asymptomatic, and making Charles just another coincidental IgA deficiency diagnosis that's come through our doors. In IgA deficient patients, the common finding is a maturation defect in B cells to produce IgA. However, the genetic basis of selective IgA deficiency actually still remains unclear. In at least some cases, it appears to involve the stem cells, as IgA deficiency has been transferred by bone marrow transplantation in some cases. The prognosis is good in patients with IgA deficiency if it's not associated with significant disease, which is helpful. We've also found that IgA deficiency in children can resolve over time. At the same time, IgA deficiency can also progress to common variable immunodeficiency, which has a less favorable outcome. Because of that, Charles is being followed for clinical and immunological findings related to his IgA deficiency. So our takeaways from today and from all of the kids that we've seen, looking at the 4-step testing for primary immunodeficiencies starts with CBC and quantitative immunoglobulins. And as we saw in many of these cases, these 2 tests were enough to indicate to us that there was a primary immunodeficiency and that follow-up was necessary. age-appropriate reference ranges are vital to be able to catch many of the primary immunodeficiencies. Many PID tests require live cells. Pre-analytical processes then have to be carefully implemented to make sure that the cells remain viable for the testing that's being done via flow cytometry. Laboratory testing is vital for diagnosis of primary immunodeficiency, as well as for rule out of all of the differential diagnoses that we see associated with so many of these kids. And the same primary immunodeficiency can have many manifestations, so it's important for us to think zebra. I'd like to acknowledge the Department of Pathology and the Division of Clinical Immunopathology at UPMC, as well as the Division of Pediatric Allergy and Immunology, the University of Pittsburgh's Department of Pathology, as well as the patients and families at UPMC. And I'll take any questions.
Thank you, Dr. Willer, for your informative presentation. We will now start the Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many questions as we have time for. Okay, let's get started. Our first question is, for the PI stages of testing, IgG subclass analysis is mentioned as part of step 2. Can you further elaborate on subclass testing?
Definitely. So subclasses are pretty standard, either as an in-lab assay or a send-out assay. When there's suspicion of a primary immunodeficiency, but the primary isotypes IgG, A, and M are coming back normal, it's necessary for us to look at subclasses to determine if an immunoglobulin subclass deficiency is actually the root of the symptoms we're seeing. IgG subclass deficiencies can be in any one or combination of the 4 IgG subclasses, 1, 2, 3, or 4. And particularly when total IgG is within the normal age-specific reference range, do we need to be looking at subclass testing? We also use subclass testing a lot in patients that have specific IgA deficiency, because it's not uncommon to see IgA deficiency coexisting with a subclass deficiency, and that changes the risk stratification for these patients. The most common subclass deficiency with IgA is IgG2, although IgG4 is sometimes seen as well. And since, as we just talked about, IgA deficiency can also evolve into the more severe common variable immunodeficiency. That is because it can evolve into CVID a little bit more frequently. As that's happening, often there's a decrease in IgG subclasses that occur before a decrease in total IgG, and so we can be more proactive with our treatment if we detect that decrease in subclasses first. We also use subclasses as a part of looking at those that have symptomatic IgA deficiency regularly to be able to catch that CVID change. Also, in trying to diagnose common variable immunodeficiency by itself, that is a very complex set of tests, and many of the algorithms include subclass testing. We also use subclass measurement in determining a revaccination strategy. So some subclass deficiencies are correlated with a lack of vaccine response. For example, IgG2 deficiency in patients which have antibody responses to only a subset of polysaccharides in the 23-valent pneumo vaccine has been noted. It's probably also worth discussing that on finding a subclass deficiency, it's important that we follow up measurement a few weeks to months later to confirm that the deficiency is not a transient deficiency, and then also that we do further testing, including poor antibody response to vaccine challenge, before we can classify a clinically significant deficiency in IgG subclasses and begin treatments.
Thank you. Now, what specific tests do you recommend when selective IgA deficiency is suspected?
Great question. So diagnostic testing is really, first line is the quantitative immunoglobulins for this. So we see that that's how asymptomatic IgA deficiency is often found, as happened in our last case. IgG subclass testing can help to determine if there's also an underlying subclass deficiency that may increase patient risk for infection or poor vaccine response. If the patient's presented with symptoms that could be consistent with an occult infection, we obviously have to do the relevant microbiology testing to be performed with particular attention to opportunistic infection possibilities in this immune-compromised patient subset. Other common comorbidities that may require testing and attention in IgA deficiency, I believe it's about a quarter of patients that have symptomatic selective IgA deficiency that also have autoimmune diseases. So rheumatoid arthritis, eczema, lupus are all reasonably common, and obviously appropriate referral to a rheumatologist and testing with CRP, RF, anti-CCP, or ANA may be indicated if that's consistent with their clinical symptoms. Celiac disease may also be more common in these patients, and IgG testing for tissue transglutaminase and deaminated gliadin peptide can help with this diagnosis. Obviously, we're looking for the IgG components since they are IgA negative, and again, only if the symptoms are present. And we also see that asthma and other allergies are common in selective IgA deficiency patients, so those can be followed up with either skin prick test or serum-specific IgE testing. Those are kind of the main tests that can help to make sure that we're catching these patients and helping them to have a good quality of life.
Thank you. Can you further comment on IgG2 subclass deficiency?
Yeah, so IgG2 subclass deficiency is definitely more common in children than adults, and as we've talked about, it's not uncommon that it's associated with IgA deficiency. It's mostly responsible for antibody response to polysaccharide antigens, so pneumonias and other sinopulmonary infections predominate this clinical picture. The lack of response to the pneumococcal polysaccharide vaccine often triggers testing for IgG2 deficiency. And in terms of development in pediatrics, the IgG2 levels actually rise more slowly to adult levels than other subclasses, so the age-appropriate reference ranges are even more important for IgG2. It also means that an incidental finding of a low IgG2 subclass measurement in children and the absence of significant symptoms should be monitored, but may not be of concern as the child may outgrow it. And even symptomatic IgG2 deficiency in childhood may normalize with age. The literature varies quite a bit, with as many as 80% to as few as 30% of children thought to kind of outgrow this IgG2 deficiency. But progression to common variable immunodeficiency is a concern, so following this up in both children and adults to make sure that there's no progression to CVID is very important.
All right, thank you. It looks like we have time for one more question. Okay, it says you mentioned in case number 4, William, that there is confusion around appropriate reference intervals of QIG. Can you please further expand on that?
Definitely. So in William's case, we received quantitative immunoglobulin results from an outside hospital, and there had been some issue with the outside hospital's data getting into our EMR. I don't specifically remember if there were no ranges or if the ranges that they had appended were adult ranges, but one of those two, and so there were not appropriate reference ranges available to him. Thankfully, he was being reviewed by an immunologist, so she immediately flagged that there was not an appropriate reference range for his IgG levels and called down to the lab. So we were able to get a hold of the outside lab and get their age-appropriate reference ranges, but those still seemed a little bit off, particularly for the IgM. So we ended up looking at reference ranges, our own in-house as well as a few other institutions to try to help tease out his diagnosis. At the end of the day, verifying reference ranges in pediatrics generally is very tough, and particularly in immunoglobulins, because they change every 1 to 2 years as a child's immune system develops. It's very important, if you can't verify the package insert reference ranges, 20 kids in each of the reference ranges can be very difficult, particularly in the very young ages. And if that can't be done, thorough literature searching as well as attention to population characteristics is very important. And method comparison can actually yield an appropriate equation if you want to try to transfer reference intervals between methods, and that's particularly helpful in pediatrics. A lot of our first-line screening with quantitative immunoglobulins is actually done by primary care physicians that are the child's pediatrician, and so there is a great need for this to turn red in the EMR so that we're paying attention to the things that are abnormal. And because of that, the reference range is very important. Recently, there has been a lot of movement towards more accurate pediatric reference ranges generally, And immunoglobulins have been a little bit slow in being included, but it looks like hopefully on the horizon we have some updated studies coming up that will help us have perhaps more improved reference ranges in PEDS.
Thank you again, Dr. Willer, for your time today and for your important research. We would also like to thank Labroots and our sponsor, Binding Site, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their questions. Any questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand, and Labroots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's event. Until next time, bye-bye.